Welcome to our first of our monthly video meetings. We are the Florida chapter of Telehealth and Medicine Today Journal. Our mission is to educate the public and healthcare professionals on the value of telehealth by promoting the publication of scholarly articles. My name is Adine Turner. I am the founder and CEO of Virtual Physical Therapists. I am honored to have as my co-chair Toni Elhoms. Toni is a nationally known speaker and recognized subject matter expert on medical coding, reimbursement, and revenue cycle management. She holds multiple credentials with the American Health Information Management Association and the American Academy of Professional Coders. She is the founder and CEO of Alpha Coding Experts, a national consulting firm specializing in telehealth reimbursement. Today, our topic is telehealth reimbursement updates. So without further ado, here is our telehealth coding guru, Toni Elhoms.
Thank you, Adine, for that warm introduction, and good afternoon to everyone. Happy Friday, and thank you for joining us for our first webinar of 2020. This is a very exciting topic for us. We can't wait to give you some great telehealth updates for 2020. Just as a reminder, as you're hopping on, if you could mute your line, we would greatly appreciate that to eliminate all background distractions. So we want to first define telehealth from a payer perspective. And this is really important because some of the new codes that have come out for 2020 do not meet the CMS definition of telehealth, which is great because it opens us up to so many more opportunities. And it's no secret that telehealth has the potential to improve access to care, to reduce healthcare expenditures. The opportunities are just truly limitless. And for a long time, we've had a lot of inconsistency across payers and states in regards to coverage for telehealth, and that's starting to shift. We actually saw some great updates in 2019, which we'll talk about in just a minute. So telehealth is defined as the use of sync or async telecommunication technology by a telehealth provider to provide services, including but not limited to assessment, diagnosis, consultation, treatment, and monitoring of a patient. This is really important because monitoring of a patient is something we're going to discuss a little bit further on, as well as transfer of medical data and education, public health services, and health administration. Also very important to understand, telehealth does not include audio-only telephone calls, emails, or fax transmissions. I know that's a common misconception with telehealth, and the great thing about some of these new opportunities that we're going to discuss is that they don't fall under the very strict CMS criteria of the originating site, the geographic region restrictions, and the requirement that services must be synchronous live video. So some of these really strict limits that we've seen on telehealth, those limits are still there, but if you understand how to categorize the telehealth services, some of them don't actually fall under that very specific definition. So what's the difference between sync versus async? So synchronous technology is synchronous telehealth is real-time video, things like online discussion groups, and then our async is file sharing, email messages, alerts, audio clips, secure texting. These are all different forms of telehealth. And a lot of people have this misconception that telehealth is strictly a Skype visit with your provider. And so these definitions really help paint the picture as to all of the opportunities with regards to telehealth. And it's constantly evolving, constantly changing, especially as technology continues to evolve and enhance our ability to not only communicate with our patients on a more regular basis, but also to have consumers really partake in the process and dictate some of the things that they have been wanting. And there's just so much opportunity with telehealth. Specifically in Florida, we represent the TMT Florida chapter. Here in Florida, we had some really exciting news in 2019. The telehealth laws of Florida were established, and this gives us very clear directions on standard of practice for telehealth services, what that should look like for patient evaluations, record keeping, controlled substances prescribing. And the other great thing about this legislation is that it authorizes out-of-state practitioners to perform telehealth services for patients in Florida. So before, there were a lot of restrictions on where the provider could be and if they could be reimbursed for the services. This update is monumental in relaxing some of those restrictions. Now, you do want to keep in mind there are some specific eligibility requirements, and you do have to register with the Department of Health. They are still rolling this out in Florida, so it hasn't been fully launched and implemented, but this is a landmark legislation, and we're really excited about the opportunities that are going to open up for providers. And I know we have a lot of physical therapists on the line, and I'm excited to give you some updates on specific codes that you're going to be able to take advantage of. So in Florida, licensees can already provide telehealth services to patients in Florida that they can treat in person. Again, there are provider restrictions, and some of those have changed and evolved. And again, telehealth is very specific to the state. And we've seen that Medicaid, for the most part, has been the payer that's really jumped on board with telehealth. They've seen the reimbursement opportunities. They've seen the healthcare expenditures, the costs go down, and it really pays for itself. And so there's a lot of coverage out there for Medicaid, and we're starting to see even more coverage with commercial payers. So it's a really exciting time for telehealth. So as we all know, coding data affects so many different things. It's not just simply codes that are slapped on a claim form and then pushed out. They actually affect so many different things. And when you're in private practice, your compensation and your business's bottom line is directly impacted by your coding data. So it's really important that you get it right, you're maximizing revenue, and you are mitigating risk if at all possible. Also, your coding data affects MACRA, and by MACRA, I'm talking about your MIPS and your APM quality programs. These are not going away. They're getting bigger, and the reimbursement incentives and penalties continue to go up each year. So each year, we're seeing a percentage go up, and that percentage reflects an opportunity or a penalty because you haven't invested the resources to be successful in quality reporting. Quality reporting is not new. We've seen this with meaningful use, PQRS, and it's not going anywhere as we see the pendulum shift from volume-based care to value-based care. So it's really important that providers understand the connection between reimbursement and quality measures and quality programs and how that impacts your bottom line. Also, patient satisfaction. As we continue to move into this price transparency world where people have access to all of the data before they make decisions, this can make a huge impact on your patient satisfaction ratings. Patient outcomes. This is really important. Again, with the more data we have, the more evaluation we can do on results and things that are working, things that are not working. And then reimbursement data affects the reputation of the provider. And I see a lot of providers that they don't see how important this is and how it really connects with your reputation. I'll give you an example. When you go on some of your insurance sites and you look for a specific provider in your area that accepts your insurance, oftentimes the insurance company will profile the provider based on their high cost designation. So if you are continuously billing high levels of evaluation and management services, or your costs are a lot higher than some of your peers in that area, they begin to profile you. And so we're seeing more and more of that. Payer sources. So it used to be just a handful of payers out there that you had to deal with. Now we've seen an explosion of insurance companies and plans offered in those insurance companies. And so this is where it gets really complicated. Medicare obviously is a big one, Medicaid, state specific. And then we have lots of managed care plans, commercial insurances. Again, that's where we're getting really specific, especially with the expansion of the Affordable Care Act. And then we're seeing a huge spike in self-pay because we're getting a lot of these direct to consumer, direct primary care initiatives, and patients are getting smarter because they're seeing that they can pay less out of pocket as a self-pay patient for a lot of services that they would pay more for if they billed their insurance. So this is where it gets complicated, and it necessitates a solid revenue cycle management infrastructure. You need to have this infrastructure in place before you start billing insurance companies. And I know that sounds, maybe a little bit too much, but you can't be too careful. And you want to make sure when you're signing contracts with insurance companies, you're telling them that you agree to all of their rules and you understand their guidelines and their payer policies. And so when in reality, it's very difficult to actually keep up with all of that information. And their policies change so frequently that it's really a full-time job. So I know a lot of providers, when they first start out, they kind of do everything. They're treating patients, they're doing the back office stuff, they're sending their claims, they're fighting with insurance companies. As telehealth specifically expands, the infrastructure that you need behind the scenes becomes that much more imperative. Also, revenue integrity. So you want to have a really robust revenue integrity program because you want to make sure that you are capitalizing on all opportunities for each year. The changes, it's the end of January, so we had new code updates January 1st. Are your services being billed correctly? And that goes back to correct coding and following guidelines. And are your services being paid correctly? So I cannot tell you how many times I've worked with providers and they don't look at their payments to make sure that they're getting reimbursed at the rate of their contract level. So don't just take their word for it. You actually want to do a manual review on each line item to make sure that you're getting every dollar that you're supposed to. So place of service 2, this is our defined telehealth place of service. And this is not new. This went into effect in 2017. Now there's been different modifiers that payers have recommended with regards to telehealth. That's very specific to the payer, so I won't go into that too much. But if you are submitting claims for telehealth services, you want to make sure that you're using the correct place of service code. So some new codes for 2020. This is where we really get into understanding the distinction between technology-based services and telehealth. So these codes for remote physiologic monitoring are specific to technology-based services. And this is an important distinction because these codes don't meet the CMS definition of telehealth, which is two-way live audio-video conferences. That's what they define telehealth as. So for these codes, you can actually report these, and the reimbursement is really good. It's anywhere from $18 to $60, depending on where you're at in the United States. Again, specific to the plan and the policy and coverage determinations. But these are some new code opportunities. You want to make sure that you have good documentation in place to support all of these services. And we're not going to go into that too much because we could literally be here all day talking about the specific criteria for each one. Make sure that you have an up-to-date CPT manual. So the 2020 CPT manual, it's imperative that you have that, make that investment. It's not expensive if you look at the big picture and the cost of what happens if you're not using correct codes. So CPT codes 99453, 99454, these are great opportunities. And then when we look at remote physiologic monitoring treatment management services. So for 2020, we actually had an additional add-on code that we can use to report all of the additional time in a calendar month. So this is where it becomes imperative that you have that tracking system in place. Some electronic health records have tracking systems and some don't. So you want to make sure you have this stuff figured out before you roll out any telehealth services. Also, keep in mind, these services can be reported by physical therapists. I know we have a lot of physical therapists on the line. These are specific to PT, so you can report these codes. These reimburse anywhere from $32 to $43, again, depending on where you're at in the United States area. So also taking a look at the new online evaluation and management service codes. So I want to remind everybody, these are physician specific. So physician, nurse practitioner, physician assistant, these are 99 codes, evaluation and management codes. So no changes there, but these are for providers that are working with established patients, and there are some specific rules for these new e-visit codes. And we'll talk about these codes, and then we'll talk about the other provider type codes. But these codes are specific to established patients only. So you can't use these codes for new patients. The CPT definition of a new patient is have they had a face-to-face with the provider within the last 3 years, and it's based on the specialty. And then there's some additional requirements, but just keep that 3-year rule in mind. You can't report e-visits that fall under a procedural global period. The e-visit must be patient initiated, and it must be initiated through a HIPAA compliant platform like a patient portal. So this is where good infrastructure and solid workflows beforehand can really pay dividends as far as compliance. There's also a frequency limitation on these codes of 1 time per 7 days. There must be a permanent record of the encounter in the medical record. And if a separately reportable E&M service occurs within 7 days of the e-visit, then the work devoted to the e-visit is included in the E&M. So that's where it gets really specific to guidelines and bundling rules. These codes pay anywhere from $13 to $50. Okay, so let's talk about the healthcare professional online digital evaluation and management codes. So these codes are CPT specific. So Medicare is not covering these codes. They have their own version of these codes, which we're going to talk about on the next slide. So 98970 through 98972. And the great thing about these codes is that physical therapists can report these codes, occupational therapists, speech language pathologists. There's lots of opportunity for providers that have not been able to bill some of these services in the past. Now, they reimburse anywhere from $15 to $40. So you're probably thinking, okay, well, how do I report these codes if none of my patients fall into that established patient criteria? So I know a lot of practices kind of use a hybrid model of telehealth services for cash pay patients, and then with these new opportunities, being able to report this to insurance. So there may be some opportunity for the initial visit to be billed on a cash basis, depending on how your practice is structured. I don't want to go into that too specifically, because it can get a little complicated depending on where you're at. But these new codes are a really great opportunity to maximize the in-between work that happens with your patients before they actually come in for their next evaluation or visit. And then we have our G code. So Medicare was not happy about CPT's terminology for evaluation and management in the context of non-physician practitioners. So they created G codes, and these are, again, the cross codes for the codes on the previous slide. No real difference here. They pay anywhere from about $12 to $33, depending on where you're at. But these are another great opportunity, again, with Medicare, because Medicare has not covered these codes before, to kind of jump on that bandwagon before we see even more services rolled out with telehealth. So there's some great opportunity and great updates with 2020. And I hope that you're able to take this information and put it into practice and hopefully capitalize on some of these technology-based service opportunities. So that concludes my part. I'm going to turn this back over to you, Aideen.
Well, I look at real world insights, and of course, when you're in the battle, it's more like your wounds. So Virtual Physical Therapists is a company we started over 3 years ago, and we were well versed in telehealth billing. And we were able to secure some direct contracts with the large self-insured companies that everybody wants to do. But most of those large self-insured companies don't oversee their medical billing. They go through a TPA. And so they usually ask, can you just bill traditionally? And of course, all we have to do is, there's a place of service, box 24B on the HCFA 1500 form. We just change the location to 2. Instead of, for physical therapy, the traditional PT practice is an 11 in that box. So we were excited, we were getting patients, we submitted our billing correctly, everything got denied. So we contacted the TPA, which was one of the top 3 large TPAs, and we were told, we don't recognize 2 in box 24B, you need to change that to 11. So I was like, okay, that sounds great for you, but for us, we'll be taken up on insurance fraud in about 2 years. We cannot change it to 11 because this is a HIPAA regulation as well. It has to be 2. I fought my way up through the chains, months it took, and I heard the same thing over and over and again. With these large companies, they couldn't change their computer system. So as soon as we submitted our bills, their computer system was going to deny it. I don't know why they couldn't do it manually. I guess they're just too big. So we fought and fought 9 months, a year before we started getting paid. So again, that's 3 years ago. That was one TPA. So we were able to change things there. But this is a slow process. You got to be in it for the long haul. So even though we know the proper coding and billing, doesn't mean you're going to get paid in 4, 6, 8 weeks. You will more than likely get denied initially and have to keep going back. Another quick story I'm going to give is about the HSA compatibility and IRS qualifications. This is something, again, we didn't realize. These are another one of our battle wounds. As a non-physician, we're the redheaded stepchild in telehealth. It's really difficult to get in network with any of the big insurance carriers. You know, we've tried and tried, we've gotten denied because we're told over and over again, they don't make direct contracts. They already have them with Teladoc and MD Live, and they won't make any other direct contracts. Well, so we again secured some really great companies. They wanted us on board they saw our outcomes for musculoskeletal problems. They wanted us on board to get control of their high costs. So we were starting to implement, and then their lawyers looked into it. If a company has an HSA, that's a tax advantage bank account. The funds that are deposited are not subject to federal and most state income taxes. So to be eligible for an HSA, the individual must enroll in an IRS qualified high deductible plan. The IRS then comes in and defines specific parameters of how that high deductible plan is designed. So they have deductible minimals and how that plan functions, such as all the expenses, including prescription drugs, must be subject to that deductible. So because of the IRS rulings, we were not able to render our services unless we were a preferred provider under one of the insurance companies. So again, we secured these couple of these big businesses, but we were unable to go forward because there was an IRS regulation. So again, in time, this will start to change, but there's a lot, the ones that are out there first doing telemedicine, it's difficult because we are paving the roads. But hopefully in the future, it'll be a lot easier. The next line I'm going to talk about is parity. And this is something great. Parity means equal. So when a state passes a telemedicine parity law, it means that private payers in that state have to reimburse telemedicine the same way they would for in-person. So I threw together a map of the states, and you can see the dark green is the states that do have an active parity law in place. The light green, basically they do as well. There's some minor limitations. The red states don't have parity, so private payers are not legally required, but again, many insurances will pay for telemedicine anyway for physicians. Non-physicians is where we get a little bit of, there's gray. And this is where if you're a non-physician and you're trying to bill for telemedicine, you're gonna have a fight ahead of you, but in time this will change. Some states do mention specific professions. Because I'm a PT, that's where I know the most. So some states do say physical therapists are a provider that they recognize and parity does have to include for them, while other states just Medicaid only mentions it. But we are actually going to talk about parity in our next seminar. We are going to be hosting monthly educational seminars. The next one's going to be on February 21st at 1 p.m. And I'm going to stick up a polling question, because we want to know what you're interested in, what our topics should be. Again, we want to promote telehealth and its outcomes. So one of the things we could talk about is requiring regulation. What are the required regulations for telehealth? Essentials that you would need before starting your own telemedicine company. How to get published in our journal, TMT. Some people want to know, we'd like to see a live demonstration. How is it possible to perform an evaluation virtually? We're musculoskeletal experts, and I would love to share that with you so you can see how solid our exam is. Another big thing that's coming up is this 5G sensor automation. The reason it's getting a little bit sticky is China has been working on it for the past 20 years. We have not. So they have all the patents on it. So that gets kind of scary if China has all the patents on all of our sensors. So that's another topic we could discuss. So I'm taking the poll and I'm going to leave it up for about another minute. So just let us know what topics you would like us to talk about, or you can actually reach out to us on LinkedIn as well. So I would love for you to to subscribe to our TMT journal. It's free to all of our listeners. You can subscribe at telehealthandmedicinetoday.com. Please also join us on Facebook and our LinkedIn pages for more discussions and resources. Thank you for joining us today. A recording will be available on all of our social media groups. We hope to have you back for our next educational seminar on February 21st. So for any of our listeners currently providing telehealth who would like to share your outcomes, please submit your manuscript, because we want to show the positive outcomes of telehealth. Thank you very much.